Greetings, everyone. This is Eric Glazer, and welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform you, our audience, but also unearth bright spots, successes at health plans, hospitals, and other healthcare organizations around the nation. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this very episode can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. If you have not subscribed to this podcast, what are you waiting for? Please do so. Leave some comments. The more ratings, the more subscriptions, the more comments, the more peers in the industry find the show and get access to the wealth of information shared by not me, but our guests that could really make an impact on our industry. So please do me the favor and help this show go more and more viral by rating it and subscribing it. Okay, let's get started. We have a very cool guest here to talk with us today. His name is Fred Turner, and he's the Chief Executive Officer and co-founder of a company called Curative. He is a British scientist from West Yorkshire, now relocated and calling Austin, Texas his home. He attended a little-known university called the University of Oxford. Maybe you've heard of it. He was named one of the top 100 practicing scientists in the UK by the Science Council 2013 and was included in the Forbes 30 under 30 list and ranked first in the EU contest for young scientists. Okay, now who is Curative? I'm not going to get into all the weeds about Curative because you're going to want to hear that from Fred, but they are and have been a critical in helping lead this nation in bringing COVID-19 testing and vaccine administration resources in response to the pandemic to all of us, having provided more than, get this, 32 million tests and 2 million vaccines across thousands and thousands of locations in most of this country, and then concurrently launched a first-of-its-kind health insurance plan that offers unmatched transparency into healthcare costs. So, Fred, welcome to Bright Spots in Healthcare. Really excited to have this conversation with you.
Yeah, thanks for having me on.
Let's start. I know I gave a little bit of a read there on who and what is Curative, but why don't you tell us in your own words what is Curative?
Yeah, so we're a new health plan focused on actually delivering preventative care. So the plan design is very simple, but very unique. Basically, all members start with no out-of-pocket cost. So no copay, no deductible, no coinsurance, $0 out-of-pocket to access any in-network provider. And everybody gets that for the first 120 days of the plan year. And as long as during that 120 days, they complete what we call a baseline visit, they'll continue to have no out-of-pocket cost. But if they do not do that baseline visit, it's basically a 1 hour Zoom call, right? 1 hour a year to engage in preventative healthcare. If you don't do that, then on the 121st day, you will revert back to a $5,000 deductible and 20% coinsurance. So it's a big carrot and stick to actually drive people to engage and think about their health just once a year. And it is very effective. We get 98% of people actually completing that visit, and we're able to get them connected to the care that they need very effectively.
Okay, so really interesting. So $0 copay, as long as I engage in a 1 hour approximately virtual, sounds like primary care visit. Is that?
Yes, it's really a mix of like an onboarding to the health plan with preventative care visits. So it doesn't replace primary care. It doesn't replace in-person care. But that first 30 minutes, you meet with your care navigator. So this is somebody who's assigned to you for your entire life on the plan. You can text them, call them, email them. They will basically do whatever you need to do to navigate healthcare. They will sit on hold with the provider's office to help you make an appointment. They can help with a prior authorization, anything you need. And in that first 30 minutes, they are educating you on how does a plan actually work? Like, what is a copay? What is a deductible? Because we find 20% of people come through and they actually have no idea what those words mean. So there's no point telling them you have no copay, no deductible, because they don't know what that is. So they're like, well, did I have one before? It isn't useful until you get that basic level of health literacy. And so we can go over what is in network. How do you use the search tool? Let's look up your doctors. Do you have a doctor? Do you have any outstanding care needs? What is a drug formulary? Is your drug on the formulary? And kind of getting that basic level of just health literacy so that everybody comes out of it actually understanding the benefits and how to use them. And we just kind of set up that relationship with the plan very differently, where usually your first interaction with the health insurance company is when you're angry about something, right? Something's gone wrong and you're calling because you've got a bill or your doctor's out of network or something bad happened. But here, your first interaction with the plan is this positive experience of the plan trying to actually get you to engage in care. And that sets up things differently. So that's the Care Navigator. And we follow it up with a 30-minute clinical visit with either a nurse practitioner or an MD. And that's really focused on finding gaps in care, right? So finding people who maybe haven't been to a doctor in 5 years, 10 years, ever, but kind of know in the back of their head that somebody told them they're pre-diabetic or somebody told them that they're hypertensive, but they haven't done anything about it because if I go see a doctor, that's going to cost me $200 and then they're going to prescribe me some drug and that's going to cost me $50 a month. So I feel fine. I'll just leave it alone. Right. And that's the kind of mentality that we're trying to fight.
Well, I'm going to break down the principles here and then we'll get into sort of the business model later. But it sounds like, okay, it's a virtual onboarding visit so that your navigator could, one, educate the member face to face. There's no better way of doing that on what everything healthcare means, educate them a little bit about their situation, and then potentially get them to the right care. And what you're doing is you're essentially paying the consumer to do that by offering them $0 copay the rest of the way. And the penalty, if you don't do that, is you're going to be beholden to covering the first $5,000 of your healthcare costs if you don't do it.
Right.
So far, so good. And so now that we've got and is this just the first time within the first year, or do they have to do this sort of onboarding?
So every plan year. I think the other just point to add is we exclusively sell to employers. So this is a large group employer product.
Okay.
So it's every adult, including dependents, must do the baseline visit every year.
Okay. So any member, me as the dad, my spouse and the caregiver and the kids all have to have their individual virtual onboarding visit.
So children don't have to do their own unless they're over 18. But yes. Yeah.
Okay. So I love this. And we're going to get into how it works. And we're going to get into a little bit of the business model about it too, because I want folks to be thinking about how the heck this could actually work. How did you identify, this overall principle and the overall concepts?
Yeah, I think one of the really key kind of design principles behind this has been simplicity. Right, we coming from the COVID world where we grew up to about 7,000 employees, we could never find good health insurance for our 7,000 employees. And you look at these plan designs, and they're just so complicated. Right, it's this split deductible, and then this family deductible, and this max out of pocket, and these co-insurances, and people's eyes just glaze over, and they have no idea what it actually is going to cost them to get care. And so we wanted to design a plan that is simple enough that every member, right, not 80% of members, every member would actually understand, what is it going to cost me to get care? And we think the only way to make sure everybody genuinely understands is to make that number zero. And so we wanted to build a plan around that concept where there wouldn't be this cost barrier. And even it's more than even a cost barrier, it's like the fear of cost. Even if the cost is actually zero, people hear these horror stories about a friend who went for a preventative visit that turned into a diagnostic visit, and then they got a massive bill. And it's that fear of the unknown of what your pricing might be that puts people off going and getting the visit. And then ultimately that comes back to bite you in the long term, right? That missed preventative visit is going to show up as an ER visit or a hospital stay or specialty drug spend downstream that could have been a simple primary care visit.
So just real quick before we move on to the next question, $0 copay, is that also including drug copays?
So most drug copays, yes, 98% of drugs are available at a $0 out-of-pocket cost. even including brand name specialty drugs. The way we have the formulary set up, it's a custom formulary designed in-house, and for every condition, there is a drug available at $0 out-of-pocket cost. So if for your disease, the only thing that's available is expensive brand name specialty drug, it'll be zero. Because there's ultimately no point charging that member $100 a month for a drug that costs $300,000 a year, right? You're not meaningfully contributing to the cost of that drug. All you're doing is encouraging the member not to take it. And if the member needs that drug and they don't take it, they're going to end up in the hospital, and you're going to end up paying for that at some point as the insurance company. So we want people to take their drugs. However, if you have a disease where there's multiple drugs available with different price points, say a biosimilar and a brand name, or a generic and a brand, the lower cost but most medically effective drug will be at zero, and the other more expensive drug will have an associated copay. Or sometimes if the price difference is particularly dramatic, it'll be excluded, like Humira and the biosimilars, for example. We entirely exclude Humira. But 98% of drug fills happen at $0.
Okay. Well, let's get into sort of reality here, because this sounds super interesting. And where is this playing out?
Yeah, so we've been in the market in Texas for about 18 months now. And so we're really starting to see results and see the effect of this. And I think a lot of people, when we first launched this, thought that, we're just going to see this crazy utilization. We're going to see, people spend all of their lives going to see the doctor. Coming from the UK, I definitely have a bit of a different perspective on that. We have copays on prescriptions in the UK, but not on any medical visits. And people have better things to do than go to the doctor all day long, right? So we don't see that increased utilization. We actually see decreased utilization on the inpatient side. So we're seeing over that first 18 months of claims, our inpatient costs are 30% below a Milliman well-managed benchmark. So the Milliman well-managed benchmark is kind of like an aspirational goal for health plans, right? Usually plans don't ever get there, right? It's what you're aspiring to get to. We're 30% below that in terms of inpatient admits and bed days. And the reason that's happening is we're able to actually engage people earlier in their care journey, get them to go see, a primary care doctor, even urgent care, sometimes even getting an ER visit that happens earlier that avoids that hospitalization, right? If you have somebody who puts off the ER because they have a $500 copay for ER visits, and they put it off and put it off and put it off until they're now dying, now it's a 1-week hospital stay, when maybe if they went the day before, it would have been a $2,000 ER visit, right? So getting people to engage early is really allowing us to decrease those long-term hospital costs. And it's not just our data, there's plenty of other data on kind of the long-term effects of cost sharing and what happens. There's a really good study that the National Bureau of Economic Research did in 2015 that followed this group of 50,000 members that moved from almost no deductible to a high deductible plan. And in the first year, they saw a 12% reduction in claims cost. So it looks like, okay, great, these high deductible plans, people must be out there price shopping, they must be avoiding unnecessary care, right? They're going to high value providers. Unfortunately, when you dig in and look what's happening, there's no evidence of price shopping, even within 3 years of the plan, right? People just don't price shop for healthcare, unfortunately. All of your claim saving is coming from preventative care. Hospitalizations were flat, specialty drug spend still went up, but you're seeing people just put off their preventative visits, no vaccines, no mammograms, no colonoscopies, right? They just cut out the preventative. And so by the second year, you can already see that with your claims costs basically going back up to baseline. And by the third year, you're 20% above baseline. So if you measure it over 3 years, you actually spend 8% more. The problem is 3 years is a long time. So, after 3 years, people say, well, what did we do last time healthcare costs increased? We put up the deductibles and it worked last time. You just kind of go around in this cycle, right? It's like Stockholm syndrome, where you're stuck passing ever more cost onto the member, thinking that is somehow solving it, when really all you're doing is kicking the can down the road, right? You're getting this member to defer some care that they probably needed this year and get it next year in a higher acuity setting. So we're trying to run that backwards, get members to engage as early as possible, get them that care early in a lower acuity setting, and avoid those long-term hospital costs. And yeah, we're already seeing that in the first year's worth of claims data.
So, quick follow up to that. So, if there's a CFO listening at a established health plan saying this is way too good to be true, this sounds way too good to be true, there's no way the balance sheet will work for Curative. Like, what do you say to that? Like, how is the business working with that kind of model?
Yeah, I think you have to look at like the economics of right how a deductible works, right? Say you have a $500,000 high cost claimant, they're going in for some transplant or some, expensive heart procedure. Your $5,000 deductible is 1% of that claim. So it isn't actually financially contributing to your high cost claimants, right? You're still, as the health plan, paying 99% of that claim. Now, what that deductible did do is prevent that patient from going and getting checkup visits that might have avoided or reduced the total cost of that $500,000 claim. And so people get very hung up on like, oh, well, what about the high cost claimants? Like, how are we going to pay for those? But the cost sharing is barely paying for those anyway. It isn't steering those procedures, right? If you have a heart attack, you're just going to the nearest hospital. There's no price shopping for those kind of things. And so all you're really doing is putting people off the preventative visits. And yeah, you save a little bit of money in the first year, but you're long-term shooting yourself in the foot. And I think it's this mentality in the industry of like, every dollar saved is good. And the reality is like much more complicated than that. Every dollar spent by health plan is very much interconnected. If you cut $1 over here, you have to check that it doesn't drive more than $1 of spending somewhere else. Otherwise, it wasn't a net positive. And unfortunately, we see a lot of these kind of crazy cases where cost sharing drives what look on the surface to be illogical behaviors, right? But that's the incentive that we've set up. It's very hard to kind of control these incentive programs. So, one example, we had a patient with Cushing's disease, which generally the treatment is, there's a small tumor, you would get a CT scan to find the tumor. If it's operable, cut it out, and then you're generally good to go. If they can't operate, the second line treatment is a drug, which is about $300,000 a year. And so we had this patient who'd been with a large national health plan, won't name any names, for the past 3 years, and had Cushing's, but refused to get the CT scan so that she could get her surgery because it would have been $500 out of pocket to get the CT because of her high deductible plan. And so because of this, the surgeon obviously said, well, I can't operate. I don't know where the tumor is. So I guess the next best thing is we'll put you on this drug. And the health plan covered that drug for 3 years, $900,000, when it should have been a $2,000 CT scan and a $40,000 surgery, right? So the incentive sometimes drive these kind of crazy behaviors that ultimately end up costing a lot more. But, somebody in that health plan will have a goal to reduce unnecessary imaging and view that preventive CT scan as a win. But you're not looking at, well, you spent $900,000 on the RX benefit because of it.
Right. I mean, it's not as clean as that because there's probably another 9 or 10 CT scans that probably were unnecessary that occurred because of that $0 copay. It's still, the math will work out.
It's an awful lot of CTs you can pay for $900,000
right.
there.
Yeah, that's right. It'll ultimately work out, is what I was saying. So tell me, is that what makes the balance sheet work? Or are you in a position where, because of the incredible health benefits you're providing that employer, you need to charge a little bit more on the premiums? Or is just the overall incentives and the way you're modifying human behavior here enough to make the balance sheet work?
Yeah, it's the incentives. Our pricing is competitive with a standard Buca plan. Okay. I think really the key with the incentives is the $0 works if you offer the $0 to everybody, right? The zero doesn't work if you only have a $0 option and you offer it alongside a high deductible plan. And this is kind of the key, because there are a handful of plans out there with kind of $0 designs, but they're usually offered as a rich benefit alongside a cheaper high deductible plan. And that doesn't work because all of your young, healthy people pick the cheaper high deductible plan, avoid all care until they get sick, and then they want to come onto the $0 plan, right? you want to get everybody on the zero plan so you can get everybody engaged in care early before they're becoming high cost claimants. And so you have to avoid that selection and make it zero for everybody. Otherwise, the economics don't work.
Yeah, simplicity again. I love it. We talked about our little Da Vinci quote we both love. Simplicity is the ultimate sophistication. I mean, you're playing it's core to the brand, the whole strategy, right?
Yeah.
With the cash that you have, whether it's from the work that you guys do with vaccinations or some of the success you're having as a health plan, like where are you investing that to just drive this model to be bigger and better and stronger?
Yeah. Yeah, there's a couple of key places we're investing. So one is on the pharmacy side. We actually own and operate our own pharmacies. We have, I think, 5 now. We'll be expanding to have some in Georgia as well. So we do free same day delivery for our members. So it's a closed door pharmacy. We have 1 in Austin, 1 in Dallas, 1 in Houston, and then 2 in Florida. And we will literally drive the drugs to the member's house same day and drop them off for free. And this goes back to what we were talking about earlier with the drug benefit is we actually want our members to take their drugs, right? We want very high compliance because that keeps our members healthy and it keeps them out of the hospital. So we have 95% drug adherence for chronic conditions, type 2 diabetes, hypertension, etc. Those are kind of unheard of numbers in the commercial space, right? We get 95% of people to take their medication. That's because we don't charge them and we bring it to their house. The only other thing we could do is put it in their mouth for them. But I don't think the compliance team would like that too much.
Is there a coaching program that you include in that, or is it just literally the financial incentive and the convenience?
Yeah, not really. So, I mean, the Curative Pharmacy is like a white glove experience, and we will reach out and check that people are doing well. But it's about half our members who use the Curative Pharmacy. The other half don't. They use an in-network pharmacy. It's the $0 and the convenience, right? People kind of know that they should take their drugs, but if you make it difficult for them, it's just an excuse to not bother doing it. And people will take that excuse all day long. So you just have to remove those barriers. So the Curative Pharmacy has been a great program for connecting with our members, making it really easy for them to get this access. And so we want to expand that nationally as the plan continues to grow. We have members in all 50 states, but we're only selling to employers in Texas and Florida right now. Hopefully Georgia will be coming soon. So we want to keep expanding that Curative Pharmacy program as we grow. The other investment we're making, it's more of an experiment at this phase, but we recently completed the acquisition of 2 freestanding emergency rooms in Houston. And so the idea here is, freestanding ERs are kind of usually a problem for health plans, right? Patients love them because they can get seen immediately. They can provide that very high acuity level of care, kind of no matter what's going on, they can deal with it, unlike an urgent care. They're open 24/7, but they often bill kind of extortionate amounts to health plans, right? And that leads to members on high deductible plans getting very large bills. And so we're trying to solve that problem by actually integrating them into Curative and owning and operating them. So members can go whenever they want. And if they go for something that doesn't really need to be an ER visit, we can de-escalate it to an urgent care. We can also do on-site observation. So, minimize unnecessary hospitalizations. It's a little nicer for the patient if they don't have to be hospitalized, if we can just do a 24-hour on-site observation. And we can make sure that they're going to the highest value hospital if they do need to be admitted. So you get that member experience that they can still use these freestanding ERs that they like going to because they have a good experience at, but you avoid that unnecessary cost and you just make it really, really straightforward for the member. So it's going to be an interesting experiment.
So yeah, Wayne, that's another episode down the road. So I just want to summarize what we've heard so far. $0 copay in exchange for you showing up to an annual wellness on-board visit that includes copays for clinical visits and $0 copay for most of the drugs. We're investing in pharmacies that we could own to create a really high-level customer experience that will drive adherence combined with the $0 copay incentive. And now we're investing in freestanding ERs at the hope that that's going to provide another convenience that will keep people from being admitted to the hospital.
Yeah,
That's
exactly.
when if I was going to ask you this question, like, because this seems just to be so simple, so pragmatic, and yet radical. Like I don't want to call out health plans names, but I could go through offices right now. I could almost see the uncomfortable jostling of the body language as they're listening to this right now. What is something that you believe that maybe you think other people think is a bit crazy?
Yeah, I think one of the things that we've discovered recently that we've been kind of leaning in on um, in terms of reducing long-term costs is cash pricing and cash price networks. So, to explain this, I got to kind of tell a bit of the background story. One of the biggest problems that we have had launching this plan is provider recognition. It actually is the thing that's definitely surprised me the most is how willing providers are to turn away patients because the front desk person doesn't recognize what the name on the card, right? And we rent First Health, which is a big national network. 1 million providers nationwide. They have, I think, 3 million members, but still front desk people don't recognize them. And so our members were getting turned away, and this was a very difficult problem for us to solve. And so the way we solved it is we actually issue our members a credit card in their name, but fully funded by Curative. And if they're ever stuck in the situation where the provider won't recognize their Curative ID card, they can just ask for the cash price and pay the cash price because they may not know that they take Curative, but they definitely know that they take Visa. And so we can always get that member seen, and we reduce that friction point, right, where the member is angry because they tried to go to their in-network provider and they couldn't be seen, right? And maybe they waited 3 months for that appointment, and now you're saying, hey, you got to come back and reschedule it in 3 months. Like, it's not good for anybody, and we want our members to have access, right? So that just doesn't work. So this zero card program has really allowed us to get members access. But then one of the things we've discovered from this that's just been kind of fascinating is that the cash prices are actually lower than the network negotiated rates about 90% of the time. So, you can actually save money by paying the cash price. Now, you would think like economic theory would suggest that payers have been able to negotiate a better rate than what the cash price is. Unfortunately, I think, the business reality for providers is they're so busy chasing around insurance companies, dealing with insurance company audits, revenue cycle firms taking 7% of the revenue, that like the simplicity of just having a cash payment and not having to deal with an insurance company and a claim makes it very appealing to actually just accept a lower price if you don't have to deal with the insurance company. So now we're kind of looking at encouraging members to use the zero card whenever they can to access those lower rates.
Love that. Do you have any data on what percentage of those physician visits are transacted through Visa versus the insurance card?
It's low right now. It's a couple of percent right now, but we're hoping to grow that substantially.
And the First Health network, you said that you lease.
Yes.
You said you used the term members. Do you mean 3 million physicians are in the network?
No, I believe that's the number that they advertise of how many like total membership from all of the other customers that they lease it to.
Okay, got it. Okay, gotcha.
The point I'm making is they're not like a small
That's right.
network.
True.
You would think people would have heard of them, but front desk people are obviously challenging to hire and retain. And by the time they're trained, they leave. And so we had this repeated issue with like getting turned away by the front desk person.
Because this just seems to, like I said, such a radical way of thinking about a benefit design. Are there any business principles, whether you learned at Oxford or in a previous life, that are sort of serve as your sort of North Star as you're founded and lead this company?
Yeah, I definitely rely very heavily on kind of trying to take things back to first principles, right? When you're trying to solve a problem, like asking, what is against the laws of physics, and then what is against the laws of the United States and the state of Texas. And if something isn't against either of those two things, right, then it should be included as a possibility and a solution. And there's a little bit too much kind of dogma in the industry of like, hey, this is how we do things. This is how it is, right? Like the only way to solve the network problem is to contract with people. It's like, well, what if we just do something different? Pharmacy has real-time transactions. Why could medical not have real-time transactions? And we already have a massive, well-distributed real-time transaction framework called Visa. Why don't we use that? Right. But it's kind of going back to first principles and saying, well, why can we not do those things? I do think, particularly in healthcare, that has to be paired very closely with listening to a lot of experts and like building a team that is the perfect infusion of a lot of industry people who've been around for a long time, seen a lot of things and kind of know why things ended up the way they are. And then a lot of like young, naive people who want to ask why 5 times. And that helps you get to the actual right answer, because otherwise you can end up reinventing the wheel. You know, sometimes there's actually a very good reason why things exist the way they are that from the outside isn't obvious, and it looks like, oh, this is crazy. This is set up in completely the wrong way. And then when you get into it, you start to understand why. So you need to kind of have that deep industry knowledge paired with the first principles approach that gets you to those novel solutions.
Yeah, I subscribe to that. I've seen that actually work and put into practice a number of times in organizations that have enough guts and trust in that, in the principle of new perspectives. And so, yeah, I love that. Love the fact that you are sharing this on the show, because it's the principal theme of the show, and it's certainly non-conventional, at least as we sit here in 2024. So really appreciate you coming on and sharing all this. I just really enjoyed learning more about it. Where can people find more if they've been fascinated by all this? Where can they find more about you and more about Curative?
Yeah, so either curative.com, we've got a lot of information there. If you're interested in the product for your employees, we sell exclusively through brokers. So ask your broker or consultant about Curative, and we'd be happy to get you a quote when you're coming up for renewal. And yeah, otherwise the website, LinkedIn is a good place to reach out as well.
And you're in Texas, Florida, and hopefully Georgia soon to follow.
Yes, we cover employers that are based in Texas, Florida, or soon Georgia, but we can cover their employees wherever they are. We have members across all 50 states, so it doesn't matter where the employees are, just the headquarters has to be in either Texas or Florida.
Fred Turner, CEO and co-founder of Curative, really well done. My message to everyone listening, a problem may look hopelessly complex, but often rather than looking for that massive cover, right, to fill that massive hole, use the strategy, I beg your pardon, of finding a bright spot, and then that is working well already, and maybe clone that bright spot as a tactic to generate progress and maybe an entire strategy at your organization to your toughest challenges, like how do you optimize value-based care? Maybe you create a $0 program for all your members. We hope you use the bright spots shared today to inspire your thinking, maybe even copy one or two. We produce this show for you. And remember, this is your Bright Spots in Healthcare podcast. Thank you very much, everyone.